Welcome, everyone. We're so glad that you're all here today. We're thrilled to be offering this event in partnership with Marin General Hospital and sponsored by North Bay Women Magazine. We're so grateful that they are helping to make this event possible today. Our bodies are changing so much as we age, and it's always surprising to me that these changes sometimes catch us by surprise, and that we as women often silently suffer through them. I don't know if it's because they happen gradually or because they're often embarrassing, we're in denial, or we just frankly don't know what to do about them. But maybe it's all of those. But I'm so glad that today we're here to find out a little bit more about what actually is going on and hopefully what we can do about it to take it all in a little bit of stride. So a quick note about the format. After our esteemed doctors present, we're going to have some Q&A, and we're going to do a mix today. If you have a question, you feel comfortable asking it, you can just raise your hand and you can ask it. If you don't feel comfortable asking it, there are note cards on the table. Raise your note cards, and we'll grab the note cards, and we will bring them up and shuffle them and get them to the doctors, because we really want to get all your questions answered. So. In as comfortable a format as possible. So we're gonna try a mix today. Some background on our speakers today. A Bay Area native, Dr. Voss, currently serves as chairwoman of Marin General Hospital's Department of OBGYN. She was honored for her practice by Marin Magazine as a top doctor in 2014. While she takes an evidence-based approach to the practice of medicine, Dr. Voss is always open to complementary and alternative options in caring for her patients. She's board certified by the American Board of Obstetrics and Gynecology. She is a fellow of the American College of Obstetrics and Gynecologists and is affiliated with Women's Medical Associates. This is such a mouthful for me to do this today. Just wait for Dr. Pathy. Oh my goodness. Dr. Pathy is a urogynecologist specializing in female pelvic medicine and reconstructive surgery. Her chief areas of focus are surgical and non-surgical treatments for all sorts of things that go on down there that I can't pronounce, and I would be embarrassed to say actually still, which is so. She's published her research in numerous peer-reviewed journals and has come to be recognized as a leader in her field. Dr. Pathy is board certified by the American Board of Urology and a member of the American Urogynecological Society and the Internal Continence Society. Whew, that's a lot. Let's just say they are experts in their field, big time. Wow, I'm really glad that you guys are talking about this stuff instead of me. So. It's an honor to have you both here today, and without further ado, I present to you our speakers.
And we'll just get the word vagina out in the open, because I know that, that's the one that everybody's a little uncomfortable with. So we say that word all the time. Really doesn't bother us at all. So obviously here we are talking a little bit about hormones, a little bit about menopause and perimenopause and what all of that means. So in the beginning, I like to just sort of talk about what the definition of menopause is, because interestingly, I found over the years that a lot of people actually don't know what menopause actually is. It has a real definition. Usually, most women experience menopause between the age of 40 and 58, and the average age is 51. And interestingly, although 40 is up there, it's actually considered slightly unusual to have menopause prior to age 42. And the people who've had menopause prior to 42, it's actually called premature menopause. But that can occur, and then we talk about that as a whole separate issue. So menopause is defined as the final menstrual period, and it is confirmed after a woman has not had a period for 12 consecutive months. So it has an actual definition. So when people talk about being premenopausal or postmenopausal, sometimes it's a little hard to know, because how do you know if that's your last period? You have to wait a whole year to figure that out. So really, that's why we have this term perimenopause, because we know things are changing, but we're not technically sure if we're actually menopausal yet. So it is a normal life event for all women. They experience it, and we try to embrace it because there's nothing you can do. It's coming, and so the hope is that we can, get through it and be happy. So perimenopause is this period of time that lasts somewhere between about 4 and 8 years before this last menstrual period. And we say that it kind of is variable because there are a bunch of different changes that occur, and some people will notice it more than others. And we call the perimenopausal window that period of time lasting until we can finally say you're menopausal after 1 year when you're after your last menstrual period. And in this window of time, there are a lot of changes that occur. You can have menstrual cycle changes, physical changes, and most women will start to develop some symptoms. They include things like hot flushes, night sweats and sleep disturbance, change in sexual function, weight gain, and mood swings. It explains everything, right? Now we know why. So I actually like to put a little slide up here that shows what we are like before menopause. So this is a month, and it just shows what our normal hormone changes are, which cause us to ovulate and have a period. So you'll see that there are a couple different colors up there. The red is our estrogen level. So interestingly, just before we ovulate, we have this elevation in estrogen, and that's actually what triggers us to ovulate. And a lot of people find that that's also what triggers a little bit of libido, because your body's smart, it's trying to get you pregnant. So it makes you want to have sex. So you get this peak in estradiol, and then your ovulatory hormones, your FSH and your LH, also peak, cause you to ovulate, and then your body's waiting to get pregnant, and then when you don't get pregnant, you have a period. And that's what happens here at the end. So this last week before the period comes, from about cycle day 21 to 28, that is the biggest shift in hormones that we have. And so most of you who recognize PMS as an issue, that's because you go from high levels of hormones to low levels of hormones in a week. Maybe not always ideal. So it's just kind of understanding what our normal cycle is and then what changes in time. So in the perimenopause window, the very first thing that happens actually is we have lower levels of progesterone. And then we have very variable levels of estrogen. So there'll be months when it's higher, months when it's lower. And actually, although that slide shows the up and down being in the menopause window, it actually starts a little before that. And so most women start to have really erratic changes in their estrogen levels in the perimenopausal window. So what do we do? Well, hot flushes are one of the most common symptoms that people complain about. And they definitely have very clear triggers. So stress is a big one. Caffeine is one, as well as alcohol, spicy foods or hot beverages or soups, tight clothing, heat, and cigarette smoke. So, of course, most people say, well, I don't know if I can avoid all those things in my life, so what do I do? So there are a lot of different treatment options, and many of them are actually lifestyle modifications. So first thing is avoiding triggers. So for people who know that they have specific triggers, then there are times when you know you don't want to have a hot flush, so you can avoid it. Exercise. So exercise is just as effective as all of the medications that are available for reducing hot flushes. So one of the very first things I ask people to do is to really concentrate on adding 20 to 30 minutes of cardiovascular exercise at least 5 days a week. So exercise works as well as antidepressants, as well as other medications that are used for hot flushes, as well as better than herbs. And so that is one that everybody has the option to try to add in that works great. And then, of course, it also helps with the next one, which is weight loss. So interestingly, women who have a higher body mass index have significantly worse hot flushes and night sweats. So being a normal body weight is actually quite helpful for reducing menopause symptoms. Stop smoking. You know, we're in Marin, so there's not a lot of smokers. So that one's not such a big issue here, but smoking is a huge trigger for hot flushes. Relaxation techniques. So one of the great things that we can learn to do is to just take a moment, learn how to do some biofeedback and relax. And a lot of times that can actually help because it reduces stress, which we know is a trigger, and can help you avoid having hot flushes, especially during the day. And then there are herbal options. So there are actually quite a few herbs out there that, in theory, may help hot flushes. This is very variable from person to person. And with herbal medications, they're not actually studied. So we don't necessarily know safety or efficacy. Most of that information is anecdotal. So the most commonly used and felt to be safe herbs include things like black cohosh, which is in a lot of over-the-counter products that are labeled as menopause management or herbs to help with menopausal symptoms. Soy foods, so not overdoing it, but a little bit of soy in the diet actually is one option which can help improve hot flushes. Flaxseed and evening primrose oil. So these are all listed simply because we know that they're safe and they may be beneficial for certain people, and so there are options for people who want to try them out. And then there's hormone replacement therapy and modulation, and I'm going to come back to that a little bit at the end because I know that that's what most people have questions about. But hormone replacement therapy and modulation works the best of anything because all of these symptoms are actually related to low estrogen levels. So hypoestrogenism is the reason that we get menopause symptoms. And then the last thing on the list are antidepressants because they're definitely individuals who are hoping not to take a hormone, but who still want some sort of pharmacologic agent to help them. So antidepressants actually work pretty well. Night sweats. So night sweats are just hot flushes that happen at night. But the problem with them is that they wake you up, and sometimes people have to get up and change clothes. And then by having changes in your sleep, you actually have changes in your quality of life because of how you can function the following day. So we talk about things that you can do that are just lifestyle modifications to help make your night sweats better. One of them is to dress in light night clothes and have layered bedding so that you can toss off that comforter, pull the sheet on, and make sure you have a couple different layers so that it's easy to change your own body temperature. The other is natural fibers and wicking. So it's nice to have really silky, attractive pajamas, but unfortunately, they do not breathe very well. So cotton is a really good option. And then a fan is quite helpful. Some people say they open a window, but a lot of people say, if they just place a fan that kind of blows over them, then they have a lot fewer symptoms at night. And then there's still hormone replacement therapy and sleep aids, which are a different category of things as well. And then the last thing is some people actually like to place a cold pack under their pillow so that at night they can flip their pillow over and it's cold so that when they place their face on it, because a lot of hot flushes really happen from your chest up, then they have relief. And so sticking a nice cold pack under your pillow is a useful option as well. And then there's insomnia. So insomnia is a big problem actually for both men and women as we enter middle age. There are a couple things that we don't do so well. One of them is establish a regular sleep schedule. So a lot of people have a pretty standard sleep schedule during the week, but then on weekends alter that. And when you look at sleep studies, it really does show that if you have a consistent sleep pattern, you'll actually sleep much better. And we need about 7 to 9 hours of sleep every night. And there are not many people who actually consistently get 7 to 9 hours of sleep every night. So there's some relaxation techniques, and there's also this issue with screens. So screens have totally entered our lives. We all have phones, we have Kindles, and so a lot of people are reading at night with a screen. There's something about the light that comes from a screen that triggers our brain to think that it's like sunlight. So it actually wakes you up. So the recommendation is to have no screens, including TV, for an entire hour before you're going to go to sleep at night because it helps you relax. And then dark, quiet, and cool. Those are all good things for your environment. And then avoiding caffeine and alcohol later in the day. Alcohol is an interesting one because a lot of people feel that alcohol helps them fall asleep, which is totally true because it's a depressant. So you do fall asleep much quicker when you've had some alcohol. The problem is it actually interferes with your sleep cycle. So you tend to wake up at about 2 or 3 in the morning and you can't fall back asleep again. And so that's one of the things that if you're really struggling with sleep is a good thing to actually avoid. And then the last thing is when we talk about relaxation techniques, one of the problems with sleep is that when you wake up at 3, you start to think about all the things you have to do tomorrow. That list of endless things. So one of the problems with trying to get back to sleep is you can't turn your brain off. It just keeps thinking and spinning its wheels. So relaxation techniques are one of the best methods of falling back asleep once you've woken up in the middle of the night. That is where counting sheep came from. It's, one of those techniques that makes it so that you try to shut your brain off and keep it from thinking about tomorrow. Or what happened today. Libido. I know this is always a big topic for everybody. So this is very complicated. And women tend to be very complex in their sexual function. And sexual health is also quite a complex thing for women. Factors that contribute to a woman's sexual health and satisfaction, as well as their sexual problems, are often very interrelated, and that is the reason why there's not a lot of very straightforward options for treating it. Like there isn't a Viagra for women because we're more complicated than that. One of the things I like everybody to know is that there is probably nothing wrong. Most people think that, okay, my libido is so much less than it was when I was younger, there's got to be something wrong with me. But what the reality is that our sexual function changes a little bit over time, but it's not abnormal. So way back in college, if you took psychology, they talked about desire as being the first piece of sexuality, arousal as being next, and then climax and orgasm and resolution. So does anybody think a guy made that up? Because, I mean, really? So there's this big thing now where women are starting to look at women's sexual function, and we realize that desire, which is that I would like to go across the room and become intimate with somebody, that may not happen so much for women, especially as we age. What may happen first is actually arousal, which means you have to participate. And then you become aroused, and then you get desire, and then everything follows. So that's a little bit hard because it means that you may not be thinking about having intercourse before you engage. And that's something that is really hard to kind of wrap your brain around a little bit because you anticipate, like, I should want to stop doing dishes and go. But really what you're like is, no, dude, I got to do the dishes, and then I have to take the trash out, and then I have to help the kids with the homework, and then... So unfortunately, you have to look at it a little bit differently and try to incorporate that change into your life, and you'll be much more comfortable. Realizing that you may have to plan it or initiate it even when you're not really in the mood. And that's a tough one. So perimenopausal and postmenopausal women really often change and start to follow this pattern where arousal is the initial step. And then there is a lot of data that shows that if you are not having regular intercourse, you actually have less and less desire. So it's a use it or lose it phenomena. So you want to actually continue to be, involved, or else you're going to be less and less likely to want to. And that doesn't necessarily mean with a partner, by the way. So a lot of people have little anxiety talking about masturbation and about toys and things, but really, if you look at sexual function, you do much better if you're also helping yourself at other times. There are a lot of options out there. The other thing is a lot of women don't recognize, we're sort of built funny. The clitoris is on the outside. Like, who thought that up? That's the wrong place. It should have been inside. If we were supposed to, function the way it seems like we're supposed to. So realistically, a lot of clitoral stimulation actually is useful in bringing blood flow to the pelvis, raising desire. And so We like to make sure people are aware that that's okay. You don't have to talk about it if you don't want to, but it's okay. And then what causes decreased libido? Well, this is just as complicated, of course. So stress is a big one. You're not going to want to stop and participate if you're stressed out, you've had a long day. And so stress reduction is a big thing. Fatigue and sleep disturbance. So, these hot flushes that are waking you up at night actually can impact your libido because you're tired. And you'd really rather just go to sleep. Changes in self-esteem and body image. Oh, boy, that's a huge one. So as most women know, you definitely have body changes as we hit midlife. And it's really hard because of the way media portrays women. And there's a big piece of decreased libido that is related to people's feelings about how their body has changed. So my hope is that people can recognize that and try to embrace their changes a little bit and realize that that it is okay to have some of these body changes and really we can't prevent it. So to try to figure out how to incorporate them into their lives. Concerns about aging, that's sort of one of the similar things, and depression and anxiety. So depression and anxiety can definitely decrease people's interest in intercourse and even in just intimacy. And the other problem is that the medications that are used to treat often also reduce sexual function. So that is a medical reason why people have decreased arousal and actually have a harder time with orgasm. So managing depression and anxiety using therapy and trying to avoid medications at times may actually impact your sexual function. And then there's weight gain. So the natural progression of a woman's body is that we have decreased muscle mass as we age, and you have increased fat content. So muscle actually burns more calories than fat. So even if you maintain the same weight, your body makeup is a little bit different, and your metabolism drops because you have less muscle mass. So that also results in some central weight gain, as most people know, that muffin top. Didn't know what that was until recently, and I was like, oh, that's what that is, right over the waistband. It's nice. So unfortunately, it does mean that you have to exercise more and eat less, because mathematically, that's just how you burn calories. I know. Everybody's like, great. So moving more builds more muscle mass, then increases your metabolism, and you tend to overall do better. And plus, as I mentioned before, exercise reduces all of these other symptoms by about 50%. And then the last thing is mood swings. So stress reduction, trying to create a balance in your life, reducing your anxiety, healthy lifestyles, including good nutrition, daily exercise, self-nurturing activities. So self-nurturing activities are really tough for people. We're women. We tend to take care of everybody else in our lives before ourselves. And so trying to get to a point where you realize you're important as well, and doing a self-nurturing activity is really helpful. And then sleep. So words of wisdom. We're trying to make your transition through menopause a positive experience. It is a time of great change, and there's also a sense of freedom that you should feel, because at this point in life you can take charge, you can find out what you want, you know yourself well, you know your life well, trying to remove negative thoughts. There's been some studies that show that women who are feeling more negative about the whole process actually have worse symptoms. So you get more hot flashes, more night sweats, more mood swings if you're starting to feel more negative about the entire experience. Laugh. So laughter has been shown to reduce cancer, shown to reduce symptoms of depression. One of the most important things you can do is go and enjoy yourself and laugh. And then, of course, exercise, eat well, meditate, and incorporate relaxation techniques into your day. I'm going to save some of the hormone questions to the very end, because I know there are some, and let Dr. Pathy talk here. But we can talk a little bit about hormone replacement therapy and different options at the very end, because I know people always have questions about what's out there, what's available, what the risks, what the benefits are. And I'm going to hand it over to her real quick.
So I am going to change gears a little bit, and I'm going to talk about kind of the stuff that Jennifer had alluded to before that happens down there, okay? So along with a lot of the changes that Dr. Voss spoke about, there's a lot of anatomical changes that actually happen as well. And for a lot of us, it catches us off guard. Like, we have no idea what's going on. We get freaked out. We think this happens to only women who live in nursing homes. We don't, and we are frankly just kind of embarrassed. And studies show that oftentimes women don't even talk about these things with their physicians. So these are just some of the things that can happen and that people don't want to talk about but are very common, such as, you know, going to the bathroom all the time, leaking urine when you exercise. Sometimes women actually alter their exercise schedule as a result and decrease their activity. Sometimes women feel like their bladder has gotten smaller. They're going to the bathroom all the time and they just can't hold as much as they used to before. Or they can feel a heaviness in the vagina or a bulge down there. They can have difficulty controlling gas and even stool. So all of those things that I just spoke about are all forms of pelvic floor disorders. And they're very common. And just to kind of generalize, you can kind of break them down into 3 types. There's bladder control problems, pelvic organ prolapse, and bowel control problems. And today, for the sake of brevity, I'm just going to touch on bladder control issues and prolapse. So 1 in 3 women will experience 1 or more pelvic floor disorders in her lifetime. And that's actually quite a significant amount. So about a third of you will, if you haven't already. Yeah. So what is the pelvic floor? So the pelvic floor is basically composed of muscles and connective tissue that lie, as the name implies, at the base of the pelvis, or the floor. And its primary purpose is to support the pelvic organs, so the bladder, the vagina, uterus, and rectum. And so just to kind of orient you, so this is as if your body was cut in half and you were looking at it from the inside out. So this right here is the pubic bone, which is out in front. Right behind that is the bladder. This is the urethra, so this is where the urine comes out. This is the vagina, which is right behind the bladder. The uterus up there, the cervix right here, and the rectum in the back. So you can think of the pelvic floor, I like to think of it like a hammock. So one end of the hammock is tethered to the sacral bone, or the tailbone. The other end of the pelvic floor kind of spreads out and is attached to the front part of your pelvis. And it just kind of hangs out there and holds up the bladder, bowel, and rectum. And so this is actually a schematic of one of the major pelvic floor muscles. It's actually a group of muscles here. And so what the muscles do really is provide support for the pelvic floor, so that when we have pressure from above, it gets transmitted down. The pelvic floor there is there to block any further descent of the organs. So the pelvic floor also allows for things to pass through, so namely urine, feces, and in the case of women, babies. So the pelvic floor has to be distensible. And since we are mammals and we do give birth to live young, all mammals have this distensibility. However, humans are very unique in that we're the only mammals that are bipedal habitually. All other animals are quadrupeds or partially bipedal. And that actually poses a pretty significant, from an evolutionary perspective, a design flaw in the pelvis. So really, as a result of having to be upright, our chest and our abdomen is right above our pelvic floor. So we have a lot of pressure going down to the pelvic floor. And so whenever we cough, laugh, sneeze, additional pressure is brought down through here. And so all that's really holding up the organs of our pelvis is just these set of muscles and connective tissue. So that really, really is a setup for a lot of problems, namely damage of the pelvic floor or the connective tissues. So there are risk factors for pelvic floor disorders other than being upright and a human. So there are genetic factors. So lots of studies show that there is a familial contribution to this. So if you have sisters or mothers or aunts who've had a pelvic floor disorder, the chances are a little bit higher that you might as well. Age and life stage. So the risk of acquiring any of these disorders increases with age, as it does with menopause. Pregnancy and childbirth are also big factors. And again, you can imagine the pelvic floor has to hold up a baby. And if you have several, you have several, equivalent of, 8, 9-pound bowling balls on your pelvic floor. And over time, that's really going to exert a lot of stress. And even young women can have them. So studies have shown that about 1 in 4 women between the ages of 20 to 39 have at least one pelvic floor disorder. And this increases to 1 in 3 in women over the age of 40. There are also lifestyle and behavioral factors to it as well. Obesity, again, the same thing is lots of pressure on your pelvic floor. And smoking. So smoking affects the pelvic floor in that it really disrupts the tissue or the quality of the connective tissue, so it's less likely to be as strong and as durable. And there are also health conditions. Neurologic problems can result in nerve damage that can really impact the pelvic floor muscles. Chronic constipation, and again, that's chronic straining on the pelvic floor, can kind of exacerbate any sort of weakness there is already. And chronic cough, same thing, chronic pressure. So we'll talk about bladder control problems first, and just a little overview of how the bladder works. So the bladder is a reservoir for urine. So our kidneys are constantly making urine throughout the day, and it just gets stored into the bladder. And the bladder is controlled by nerves and muscles that allow us to expel that urine in a socially acceptable time. So normal voids, like roughly everybody on average voids between 6 to 8 times per day, and that's considered normal, and 0 to 1 times at night. And actually, as we get older, we tend to produce more urine at night. So it's not unusual for a woman in her 80s to go to the bathroom or wake up 2 times at night. So you can have problems of bladder control whenever the muscles or nerves of the pelvic floor are affected. So you can have loss of urine, also known as urinary incontinence, or difficulty emptying your bladder. So the symptoms of this can be variable. Sometimes we can have a really strong urge to go, and they leak urine before they get to the bathroom. They can leak when they cough, laugh, sneeze, jump on a trampoline, or do any sort of exercise. They can have a need to urinate constantly. And their urine stream can also change, so it can become slower, or they can have a sense that they're not completely emptying their bladder. So 18 million women currently have urinary incontinence. And what this slide really shows is that a majority of women do not seek help for it when it first starts. So only 41 seek help for it within the first year of having their symptoms. But what's more startling is that 25% of women wait over 5 years before they seek help. And there's many treatments, lots of different types of things that can be done. So it's really, quite a shame that a lot of women aren't seeking help sooner. So when we talk about urinary incontinence, I like to simplify it and think of it as 2 different types. One is stress incontinence, and that's the leakage when you cough, laugh, sneeze, run. And that's an anatomic problem. So when we have increased pressure in our chest, it gets transmitted down to our abdomen and then down to the pelvic floor. So stress incontinence is more of an anatomic issue. There's a compromised pelvic floor. So when there's pressure exerted from above, it gets transmitted down, the pelvic floor is too lax, it falls, urine leaks. So that's an anatomic issue. Overactive bladder, on the other hand, is more of a nerve issue. There's a sensation that you have to go and you have to go now, or you leak before you get to the bathroom, or you just have to go often, or you go often at night. And what that is again, a nerve issue. And so the nerves of the bladder start to contract before you're ready for the urine to be expelled. So the importance of distinguishing the 2 types of incontinence is because it's going to determine management plan or how you're going to treat it. You should initially go to your doctor, talk to them about treatment options, but before you do, there are a couple things that you can do on your own at home. One is diet and exercise. And again, if you're overweight, losing weight can make a drastic change. even losing 5 to 10 pounds can significantly reduce your episodes of incontinence or urinary urgency. Limit alcohol and caffeine. Alcohol and caffeine are both bladder irritants, and they're going to make your bladder want to start to contract before you're ready for them to do that. Keep your pelvic floor muscles healthy, and do pelvic floor exercises, and I'll get back to this a little bit later. And you may also, before you see your doctor, track how often you go to the bathroom and how often your leakage occurs. And you may also want to retrospectively review what you drink and what you eat, and to see if there's any correlation with your urinary symptoms. Some people don't realize that we actually end up drinking a lot of water. Some women drank over 3 liters. And so, of course, if you drink that much water, you're going to have urinary frequency. So, stress incontinence. And again, this is a leakage that occurs when you cough, laugh, and sneeze. It's an anatomic cause of incontinence. So, one of the most important things you can do is to strengthen your pelvic floor. So you can do that with Kegel's exercises, which I'll talk about later, but also strengthening the core muscles of your body. So Pilates and yoga are great ways to really strengthen the core, and studies have shown that both yoga and Pilates can decrease the progression of stress incontinence and sometimes actually reverse it. And physical therapy, pelvic floor physical therapy. So for women, for women who are not able to do pelvic floor exercises, a physical therapist is an excellent person to go to who can actually teach you how to do these exercises. In addition, provide other tools such as nerve stimulation and exercising additional muscles that are not directly in the pelvic floor but are accessory pelvic floor muscles. And for women who have really severe symptoms, the next step really is surgery. And again, stress incontinence is an anatomic problem, so we correct it by correcting the anatomy. And really our gold standard surgery at this time is a mid-urethral sling procedure. And that's a procedure that actually elevates and supports the bladder and the urethra. And in certain cases, some women are good candidates for a urethral bulking procedure. And that's a procedure that we can do in the office, and it really kind of fortifies the urethra. So overactive bladder treatments. Now, overactive bladder, again, is the nerve irritation type of incontinence. So lifestyle changes that you can do on your own eliminate bladder irritants, namely caffeine, artificial sweeteners, sodas, alcohol, because those all irritate the bladder. Retrain your bladder. Now, that's something that is often done with the help of a physical therapist, and some patients can do it on their own, and towards the end I'll talk a little bit more about that. And urge suppression, and again, that's another trick or technique that you can employ, and I'll talk a little bit more about that at the end. Physical therapy. Physical therapy is great. Again, same thing. If you have difficulty using your pelvic floor muscles, a physical therapist can work with you to really kind of get your muscles a little bit stronger, increase their tone as well as their strength. And medications. So there's a wide variety of medications that are available. A lot of them are advertised on TV. They tend to work actually similar to the effects of menopause. Lifestyle changes tend to be as effective as medications. So that's always the first thing that I do for patients, is have them change their lifestyle, change their habits. If that doesn't work, then we start medications. And there's now also surgical options. We actually can use Botox in the bladder. And what that does is just relaxes the bladder muscle. So similar to how Botox is used in the face to relax the facial muscles, it's used in the bladder, and it actually is really effective. It is as effective, if not more effective, than medications. And there are other procedures that involve modulation of the nerves, and that's a little bit more invasive, and it's implantation of a bladder pacemaker, essentially. So there's a lot of treatments. So the next thing I want to talk about is pelvic organ prolapse. So the symptoms of pelvic organ prolapse include a sensation of a bulge in the vagina. Some women feel like there's something coming down or something coming out of their vagina. A sensation of heaviness or pressure. Some women can have urinary problems. They can have a sensation of incomplete bladder emptying or a slow stream. They can also have bowel problems. They can feel like their stool gets trapped or they're having to constantly strain in order to get all of their stool out. And women can have pain with intercourse. So this is actually very, very common. So 50% of women above the age of 50 have some form of prolapse. And 11% of, there's an 11% lifetime risk of having some sort of prolapse surgery by the age of 80. And again, some of the risk factors for this are the risk factors for the other pelvic floor disorders, which include having had childbirth, like one or more deliveries. You have a higher risk if you have a vaginal delivery, and even higher risk if you have an operative vaginal delivery, meaning forceps or a vacuum was used to deliver the child. Being overweight, again, same mechanism, it's that constant pressure on the pelvic floor. Chronic cough, chronic constipation, same thing, straining. And being postmenopausal. So estrogen actually plays a really strong role in keeping the connective tissue of the pelvic floor healthy. It brings in a lot of really good blood supply and promotes the development and thriving of the connective tissue. So when we hit menopause and the estrogen levels go down, that tissue changes. And so this is a schematic of what prolapse is. And now back to our normal anatomy. So again, body in cross section, you're looking at it from the inside out. This is the pubic bone right here, bladder, vagina, uterus, rectum. And this is a cystocele. So what that is essentially a herniation of the bladder through the vagina. And women can feel a bulge, and that bulge is actually the vagina dragging the bladder down. You can have a rectocele, which is herniation of the rectum through the vagina. And that bulge is the rectum coming out through the vagina. And women, oftentimes these women have a sensation of incomplete stool emptying. Their stool can actually get trapped in there, and so they feel like they never empty their bowels. And you can also have uterine prolapse, where the uterus actually falls from its anatomic location here down here, and in some cases it can completely evert. It's like, it's like a sock getting pushed inside out. And women really, some women, they're so embarrassed by this, they think they're growing a penis. They don't, they live for years. I've seen women in their 70s, 80s who've had their uterus literally out of their body, and they just never sought care because they were so embarrassed. So these things are actually quite common and can be quite devastating. So treatment. So, fortunately, all of the things that I've spoken about are quality of life issues. There's nothing that's life-threatening, nothing that's emergent. So how you treat it depends upon how bothersome it is for you. It's very conceivable that it may not be bothersome at all, in which case you don't have to do anything. But if it is bothersome, there's some options. Oftentimes, I will have patients go to physical therapy. Sometimes strengthening the pelvic floor can actually be very, very beneficial in preventing the progression of prolapse. And in some cases, actually kind of reducing the severity of prolapse as it is. You can always do kind of just pelvic exercises on your own, which again, I'll talk about in a minute. And you can also use a pessary. Now, what a pessary is a silicone device that you can insert in your vagina, and it kind of holds everything up. Everything's falling down, it holds it up. It's kind of like Spanx for the vagina. It's not the best thing, but it kind of gets the job done and it holds everything in. But another popular option is surgery. So every woman's situation is different. There are a variety of different surgical approaches. And really there's no right answer for everyone. So it's important to talk to your physician, talk about your aims and your goals, and come out with a surgical plan that's the most appropriate for you. And again, the goals of surgery really are to restore normal anatomy, reduce the bulge, and improve your quality of life. And that's the goal of all of this, is to improve your quality of life. So what can we do to prevent these from happening? Unfortunately, a lot of it is beyond our control, but there are some things that you can do to reduce your risk. Big ones are to avoid constipation. Again, you want to avoid straining, anything that's really going to put pressure on the pelvic floor. So if you're constipated, increase your fluid intake, increase your dietary fiber. If you're still constipated, speak to your doctor, and maybe there's another cause that needs to be addressed. And if you have a chronic cough, address that. Again, you want to avoid the chronic straining. So people who are asthmatic, people who have chronic bronchitis, it's really important to get that under control. Weight loss. Again, this is if you're overweight. You can have significant improvement in symptoms with even modest weight loss of 5 to 10 pounds. Stop smoking, avoid bladder irritants, and strengthen your pelvic floor. So pelvic floor exercises are really good for women who have a lax pelvic floor. So there's basically 2 types of pelvic floors. Lax pelvic floors, which is when everything kind of droops a little bit, and that's kind of what most women with pelvic floor disorders have. But there's also a subset of women who have really tight pelvic floors. And a lot of those women have chronic pain syndromes. And it's not a good idea for them to be doing these exercises. So if you don't have any pelvic pain, then you can go for this. If you do have pelvic pain or any sort of pelvic floor issues that involve discomfort with intercourse especially, then I would suggest talking to your doctor first before embarking on any sort of pelvic floor exercise regimen. It's really important to do the exercises correctly. A lot of us, think we can kind of figure it out, but when I see patients in the office, they're actually doing them incorrectly. And a couple things. Number one, you're just kind of wasting your time if you're not doing it correctly. Number two, you can actually cause that tight pelvic floor later on. So it's really important that you learn how to do them correctly. Once you know how to do them, it's important to do them often. So like any muscle, you have to work it out. You have to do a little endurance training and a little interval training. So I'm going to tell you how I tell my patients to do it. So when you do a pelvic floor exercise, you have to isolate the pelvic floor. So you can't use your abdomen, you can't use your butt, and you can't use your thighs. You want to use the muscles that you would use if you wanted to hold in gas or to stop your urine flow. So I want you to contract those muscles, and as you contract, kind of imagine an elevator going up. Imagine everything going up. That's the kind of sensation you should have.
Everybody can try right now.
Yeah. And actually, if you're doing it correctly, no one should be able to tell that you're doing it. So, yeah, you can do them all the time. So, like a good starting strategy is once you are able to isolate the pelvic floor muscles, to do a couple little what we call quick flicks. So that's a quick contract, release, contract, release, contract, release, and do that 5 times. Do that 3 times per day. And then you do a little bit of the endurance training. That's when you contract your pelvic floor muscles at maximal intensity, hold it for at least 5 seconds, and relax for 10. It's important that you relax after the contraction to allow the muscle time to heal or rest. So I tell my patients to do 3 reps of 10, and do 3 reps of 10 3 times a day. And with time, you will see some improvement. It won't be instantaneous, but after 6 weeks, you should see some improvement. So now that you know how to use your pelvic floor muscles, there's a couple tricks that you can employ to reduce urinary incontinence and urinary urgency. So the big one is called the NAC. It's the squeeze before you sneeze maneuver. So if you know you're going to cough or laugh or do something that's going to result in leakage, quickly contract your pelvic floor muscles and just hold it while you cough and laugh. What you're doing is just basically temporarily providing support to your pelvic floor. The other thing you can do is urge suppression. So if you have a lot of urinary urgency and frequency, what you can do is contract, like actually before you run to the bathroom, take a deep breath, contract your pelvic floor muscles, and hold it until that urge goes away. Another trick is to do a couple quick contract, release, and that also psychs your brain into thinking you don't have to go. What we're doing with urge suppression is actually manipulating the brain spinal cord nerve pathways, and it can actually be quite effective. And again, this is actually as effective as medications over the long run. So my take-home message, pelvic floor disorders are very common. but they're not normal. So there are lots of treatment options out there, so talk to your doctors and do your Kegels.
She makes menopause not look so bad, right? So I just wanted to really briefly talk a little bit about hormones, because I know there's a lot of people who have some questions about hormone replacement therapy and kind of what options are out there. So the first thing is that it's a very unique option for each individual, and everybody decides what their preference is based on their lifestyle, their family history, their medical history, how much bother there is, because realistically, hormone replacement is a quality of life issue. And everybody has a preference on how much impact menopausal symptoms can have on their life. Because there is no magic bullet for any of this, and we're all going to go through it, you do have to sort of sit down and figure out what is right for you. So the most recent change in hormone replacement therapy has been the advent of quote-unquote bioidentical hormones, and I know a lot of people have questions about that. So the term bioidentical hormone was actually a marketing technique because women are always looking to feel better, and we really want, you know, to do the safest thing for ourselves. But unfortunately, bioidentical hormones are no more safe than other hormone replacement options. What a bioidentical hormone is basically a replication of a hormone in a laboratory that is the same as what our ovaries originally produced. So estradiol is the most common used estrogen, and it's the one that works the best. So estradiol is the actual compound chemically that our body makes. So any 17-beta estradiol that is available is technically bioidentical. So there are a lot of FDA-approved pharmaceutical options that are bioidentical, but a lot of people don't think of it that way because they're considering some of the more alternative options out there as being the only bioidentical options available. The other version of hormone replacement, or the other piece of it, is progesterone. So there's estrogen and there's progesterone. So as we talked about, these menopause symptoms are actually symptoms based on low estrogen levels. So hot flushes, night sweats, mood swings. This is all an estrogen issue. So then a lot of people say, well, why the progesterone? And if you have had a hysterectomy and don't have a uterus, interestingly, you actually don't need the progesterone, because the progesterone serves one purpose, which is to protect you from developing cancer from the estrogen. So estrogen stimulates the lining of the uterus to thicken and grow. And normally, if you recall that original cycle I showed you for the premenopause, you would notice that at the end of our cycle, we had a big bump in progesterone, and then the fall. And during that fall, that's what triggers us to slough off this lining and have menses. So without progesterone, if you're constantly stimulating the endometrial lining with estrogen, you will grow a thickened lining, and it actually grows abnormally. And about 6% of women, if they take an estrogen without a progesterone, will get endometrial cancer. So progesterone is an incredibly important piece of hormone replacement therapy for any woman that still has a uterus. And so that's one piece that sometimes in the bioidentical world is not as clearly explained. The other thing is that progesterone is really not absorbed well through the skin. We have a lot of options for estrogens that can go through the skin as a cream, as a ring, as a patch, as a gel, spray. So these are all options that are available that work great. However, progesterone creams are not very well absorbed, and so you're not protecting yourself if you use a progesterone as a cream. So it has to be taken orally. So that's another one of the things that's a bit of a struggle, because a lot of the alternative therapies use a progesterone topical, which is not safe necessarily. So there are a lot of bioidentical options that are available through a normal pharmaceutical avenue. I'm going to give you some references for, there's an excellent site called NAMS, N-A-M-S, which is the National Association of Menopause. And there's a ton of patient information available because obviously everybody's at a different stage and has different questions. And it's got lots of references for different options and what's safe and what's not, and herbs. And so we're going to give everybody that link because it's quite useful. But the recommendation for use of compounded bioidentical hormones is actually not to go that route if we can avoid it, because there's a lot more quality control issues. So it's kind of like the herbal industry. It's not regulated. So there's a lot more concern for quality control. Nobody's actually checking to see how much hormone is put in that cream and whether or not they made a mistake. And so sometimes people will actually get abnormal doses from it. It may not be absorbed as well. So when we're talking about hormone replacement, I think it's great to go in and see your doctor and talk about the different options. But we do recommend sticking with a normal FDA-approved hormone therapy regimen. The risks associated with hormone therapy are actually not that high. I know that a lot of people, obviously we're in Marin, so if anybody came to Leah Kelly's breast cancer, chat, everybody's worried about breast cancer. So the unfortunate news is that about 1 in 8 women in Marin is going to get breast cancer. It's an incredibly high number, 12%. And there is a slight increased incidence of breast cancer in women who take progesterone and estrogen together for more than 5 years. That risk is about 3 in 1,000, so it's not that much higher than the background incidence, but it is calculatable, so we can actually see that there is a slight difference. So the traditional physician will recommend that you take hormones for 5 years or less, because that's been sort of the guideline that's followed, because that's statistically when we notice a difference. That being said, hormone replacement therapy is an incredible quality of life question. If you've taken your hormones for 5 years, you find that when you stop them, your quality of life is incredibly impacted, and you're not happy, and you have lots of symptoms. I don't think there's any reason why you can't return to hormone therapy use. You have to make an educated decision on balancing the pluses and the minuses. There's also a slight increased risk of a thing called venous thromboembolism, which are blood clots. So blood clots occur more frequently as we age. Estrogen stimulates blood clot formation a little bit. So the highest risk for any woman in their lifetime is pregnancy and the first 6 weeks after you've had a baby. So interestingly, that's when we're at highest risk. However, that risk still increases with aging, with heart disease, with high blood pressure, with high cholesterol. And so hormone replacement therapy does stimulate a little bit higher risk of blood clotting. So you also have to take that into account. But the other side of that is it helps you with your bone density. So women who are thin and Caucasian or Asian have a much higher incidence of osteoporosis as we age. We're now living to be in our mid-80s and 90s, and our skeleton starts to lose bone density as soon as we hit menopause. So it's not to say that hormones are all good or all bad. There's a huge question based on what your lifestyle choices, what your risks are, and it's a very individualized answer for each person. Does that make sense? Should we do questions?
So you talked about hormone replacement, but what about using birth control to regulate your hormones?
So, yeah, absolutely. So hormone replacement therapy is a purely postmenopausal treatment option. So that slide that I showed you again with the cycle on it illustrates why, as a premenopausal individual, you can't actually use a hormone replacement therapy to manage symptoms as well, because you're already making your own estrogen and progesterone in higher levels. So hormone replacement therapy is actually a very small dose of estrogen and progesterone. So if you were to try to take that in the middle of that cycle, you might just cause irregular bleeding, strange cycle changes. So for the perimenopausal individual, the person who is still having periods, even if they are irregular, the best option is actually a very low-dose birth control pill. And I know a lot of people have been anxious about birth control pills, and really a birth control pill is not that different than hormone replacement therapy. What's the difference is the dosing. So a low-dose birth control pill to control cycle changes is actually incredibly effective at controlling PMS, mood swings, irregular periods, and so we use it quite frequently when the quality of life starts to come into play for women in their, the 8 to 10 years before their periods stop. Is that good?
If you're post-menopausal and you're still having all these symptoms, will they last for life, and why are they erratic? I mean, I have, they're great for a while, and then it gets bad again.
Well, so interestingly, most people will have most of their vasomotor symptoms, which are the hot flushes and night sweats, for about 2 to 5 years surrounding menopause, which is that last year when the period happens. However, they tend to decrease over time, but sometimes they will never disappear completely. I know. Sorry. So, and then the thing that makes them better or worse are the triggers. So notice all those triggers that we mentioned. So stress, sleep disturbances, alcohol, caffeine, all of these things are triggers. And so when people start to have worse symptoms for a period of time, a lot of times it's a lifestyle related issue. And so sometimes you can make them better by just taking a look at what's going on and seeing if you can do a little more meditation and relaxation and sleep and then there's still hormone replacement therapy. Is there a difference in the risk of hormone replacement therapy depending upon your age? For example, 45 or younger. So now, if we're talking about hormone replacement therapy as you are menopausal but early, so menopausal at age 42, for example, then most physicians feel that realistically hormone replacement therapy is actually a good idea. You would want to do that because physiologically, most women hit menopause around 50. And if you're having menopause at 42, all of these post-menopausal changes that can happen to our body are going to start sooner. So osteoporosis is more of a risk. Heart disease is more of a risk. Pelvic floor dysfunction is more of a risk. So for early menopause individuals, we recommend some hormone therapy at least until you hit a physiologic age for menopause.
So the next question is, how do you know if painful intercourse is from decreased hormones or from a pelvic floor disorder? That's a good question. And there's really no way definitively to be sure. I would recommend getting an examination, going to your gynecologist or OBGYN for an examination to determine that. Sometimes vaginal dryness is very common in postmenopausal women, and that can lead to discomfort during intercourse. And typically, dryness is pain upon insertion. So when the penis is inserted in the vagina, that's when the discomfort usually occurs. With prolapse, it tends to be during thrusting. So that's one way to distinguish between the two. But I would just definitely recommend having your doctor take a look at you.
And somebody just sent us a card that says vaginal dryness? ? So we've talked a bit about systemic hormone replacement therapy. However, there's also vagina hormone replacement therapy. So there are a couple different versions of vaginal estrogen products. So for those individuals who really prefer not to take systemic hormones or have a medical reason why they really shouldn't, there is vaginal estrogen that can help protect against dryness, help make the tissues more elastic so that they stretch better, so that penetration's more comfortable. And they come as a suppository option, a cream option, and a ring. And so they're actually quite effective at helping with dryness and with that skin thinning that makes intercourse more uncomfortable.
I think there's some questions out here.
My question has to do with when I approached an early menopause. My gynecologist said to me, we discussed whether or not I should take hormones, and he said that not taking hormones would affect my skin by as much as 25%. And this isn't discussed, and I think it's an important esteem issue for us as women. I'm a firm believer in bioidentical hormones, and I've been taking them for many years, and it makes a big difference in your skin, ladies.
Yeah, again, so certainly we do recognize that estrogens make skin more elastic. We can see it absolutely, especially in the vagina, and lots and lots of people do feel that hormone replacement therapy does improve their skin. This is an area that's not studied, so people do not really know how much of an impact it has because we don't take a group of women and put them on estrogen and then evaluate their skin for a decade, and take another group and don't let them do it and then evaluate. So it's one of those things where it's anecdotal. We definitely see that it appears that it may improve skin and hair, but there isn't any real recommendations out there for how to use that. I have a question here that says, do men go through menopause? So actually, men do not. Men produce a fairly stable amount of testosterone. It does actually decline over time. What men get is erectile dysfunction. And interestingly, the erectile dysfunction world is very much paid attention to. There's lots of treatment options out there. And in the middle of the football game, when the Libido commercial comes on, I have to explain to my kids what that is. It's always great. I talked a little bit about why women are so complicated. Men are actually much less complicated. They can have less testosterone and have less desire as they age, but it does not usually happen until quite a bit later in life than it does for women. So most men will have a fairly consistent libido, definitely through their 50s, 60s, sometimes 70s. Look at Hugh Hefner. So unfortunately, we are chronologically different than our counterparts. And that is one of the reasons why communication is key in a good relationship. Because if a man understands that your desire issues are linked to that pathway of, I need arousal before I can have desire. If they realize that it's not because of something with the relationship, that it's not because you don't love them anymore, that it's not because you're not interested, that conversation is key, because then they understand that they may have to, initiate in a different way to make it so that you have some arousal before your desire sets in. And having them understand that is very important, because they're kind of defensive. They feel like, it's me. Then they don't want to approach it, and you're kind of not in the mood. And so I really think communication, couples therapy, sex therapy works really well. If there's an issue with sexual function, it's really a couples issue, and working through it and figuring out what your new normal is.
You mentioned sex therapy. What goes on in sex therapy? I mean,
so a lot of it is just conversation of, so it depends a lot. So, right. Well, actually, erotica is useful. What? Erotica is useful. Absolutely. Yeah. I mean, you don't have to go porn. You can just go kind of erotic, Woo. It's all good. But sex therapy does a lot of, so women are complicated. A lot of times, things that bother us last for days. So, like, if he didn't take the trash out 3 days ago, you're still sort of irritated about that. And that lingers, and then it makes your desire zero, and then your arousal is kind of like, So a lot of sex therapy is actually just trying to figure out relationship-wise how you can please one another, ways of having arousal without just penetration, a lot of intimacy issues, looking at what your triggers are for irritation, anger, boredom. Yeah, you usually go as a couple. You don't have to, I don't believe, but generally speaking, a lot of this is more effective if you've got both of you there to try to work on it. I have one more here that's probably useful, which is, we'll do one more there, but this one's the difference between estrogen replacement and antidepressant therapy for PMS symptoms, probably also for menopausal symptoms. So antidepressants do have a sexual side effect often, or the most common ones, the SSRIs. So one of the interesting things about them is that they flatten everything a little bit, which is sometimes good, but they also can flatten sexual function. So they can make arousal a little more difficult. They can make climax a little bit more difficult. So there are certain individuals who are on an antidepressant who actually find that they find it harder to orgasm, that they have less arousal when they're sexually active. And so that may not be the best option for some. There's some options like Wellbutrin, which is not an SSRI, which actually does not have that same side effect. So some women who are concerned about sexual side effects of antidepressants will actually choose that option instead. And when it comes to PMS, the SSRIs have actually been studied and do reduce symptoms pretty significantly, about 50%. And we use it a little differently often for PMS. We'll have people take it only for those 2 bad weeks, not the whole month. So sometimes people will take a lower dose for just a couple weeks, right when they're having a little bit more difficulty with their moods, and that's pretty effective.